Hello everyone, today we'll be discussing Asherman Syndrome. Asherman Syndrome or intrauterine adhesions or intrauterine synechia. This occurs when scar tissue forms inside the uterus and or the cervix. The etiology. Asherman Syndrome occurs primarily after a dilatation and curettage performed for elective termination of pregnancy, a missed or incomplete miscarriage, or to treat a retained placenta after delivery. This may occur with or without hemorrhage after delivery or elective termination of pregnancy. Less often, this can result after a DNC for a non-obstetric procedure for excessive bleeding, sampling for endometrial cancer, or removal of endometrial polyps. This can also occur after surgery to remove uterine fibroids. In patients with excessive uterine bleeding which is hypermenorrhea, specific procedures can actually be done to create these adhesions throughout the uterine cavity. So this is the desired goal, to control the bleeding. What remains is sometimes a DNC can cause the adhesions to form. That will be your Asherman syndrome. However, sometimes you do it as a therapeutic measure in patients that are having excessive bleeding. You scar the uterine tissue so they stop bleeding. So these procedures are done to ablate the endometrium and create scarring. And in the developing world, this condition may also occur due to infections from schistosomiasis or genital tuberculosis. Pathophysiology. Asherman syndrome occurs when trauma to or removal of the basal layer of the endometrium in opposing areas within the uterine cavity. Such injury to the lining triggers inflammation that allows these adhesive bands to form from one side of the cavity to the other. Abnormalities in placentation, where the placental tissue burrows below the basal layer of the endometrium, significantly increase the risk of developing Asherman syndrome. The extent of the adhesions defines whether the case is mild, moderate, or severe. The adhesions can be thin or thick, spotty in location, or confluent. The adhesive bands are usually not vascular, an important consideration when discussing treatment options. History and physical examination. Patients with Asherman syndrome may have light or absent menstrual periods. However, some patients may have normal periods based on the surface area of the cavity that is affected. Others have no periods but have severe dysmenorrhea that may occur around the time of the anticipated menstrual period. The pain may indicate that the endometrial buildup occurs during the cycle, but that menstrual flow is obstructed due to adhesions near or within the cervix. These adhesions can present as recurrent miscarriage and/or infertility due to deficient endometrium and its poor vascularization. Evaluation. The failure to induce menses despite stimulating the endometrium with an estrogen-progesterone challenge in a patient with secondary amenorrhea points towards the diagnosis of Asherman syndrome. Although ultrasound may suggest adhesive disease, Asherman syndrome is more often evaluated initially with silent sonography or HST, which is the hysterosalpingography, to demonstrate the adhesions. However, the sensitivity for diagnosis is at 75%. The gold standard is hysteroscopy. That will help with diagnosing the extent of the disease, and it can allow treatment to occur simultaneously. MRI is needed when there is a total obliteration of the uterine cavity. Treatment. Usually you can ask the surgeon that is doing the hysteroscopy to remove the scars with scissors, but may also use other modalities. Pre-operative and post-operative treatment with oral transdermal or intramuscular estrogen preparation helps to reduce the scarring post-operatively and promote regeneration with normal endometrium. Prognosis. The chances of conceiving and delivery after surgery are low in patients with moderate to severe disease, but may improve after surgery if the cavity can be reconstructed and menses recur. Although a normal appearing uterine cavity may be seen after repeated surgeries. Rebuilding a normal endometrial lining may lag for some time after surgery, or it may not reoccur. Complications. Asherman syndrome can result in repetitive pregnancy loss, abortions despite surgery and treatment. Recurrence of the adhesions can be seen even after adhesiolysis. Although the risk of endometrial cancer in women with Asherman syndrome may be lower than the general population, women with Asherman syndrome may develop endometrial cancer before or after menopause. Since the signs and symptoms often found in these women, which is early or abnormal bleeding, thickened endometrium may be missed due to the scarring or cervical obstruction. Then Asherman syndrome can also result in obstetric complications that include preterm labor, low birth weight, and placental complications that include retained placenta and placenta accreta. That's all about Asherman syndrome. If you like the video, please like, subscribe, and comment. Thank you.